I'd like to welcome everybody to our Stage 3 Proposed Rule webinar. This is Scott Mash, and I'm joined with Cathy Costello, and we're going to go ahead and get started. A couple house cleaning items. Everybody has been muted by default when you dialed in. We're asking that everyone use the question box to enter your question. Just as soon as you have a question, just please enter it into that box as we're going along. And at the end, we will answer all your questions. Cathy and I will stay online until we answer every single question submitted. And I'm going to turn it over to Miss Cathy Costello.
Hi, everyone. We're so glad you could join us today. I just want to point out that on that cover slide, the monster on the right is me jumping up and down on top of the Stage 3 rules. And Scott was taking the picture of it. So believe me, if you don't feel that way about Stage 3, then you haven't read them yet. But anyway, for those of you who are on the call wondering if we're going to answer all your questions on attestation in 2015 and 2016, the answer is no. These rules do not cover the 2015 attestation. That is going to be released in a totally separate rule, which we had hoped would be out by this time, but clearly is going to have to be out sometime in the next few weeks if it's going to affect the hospital reporting. To that end, let's talk about what this rule does and why you need to be interested in it right now. And the reason is that this rule, as a proposed rule, has a lot of issues with it. There's a lot that CMS did not define yet, but what they were trying to do is to balance their need for regulating in a way that allows for interoperability to occur, balanced against new technologies coming down the road, because they wanted to capture as much of the new technology, but they aren't really sure how it's all going to fit in. So what you want to be looking at when you think about the proposal is how is it going to impact what you need to be looking for 3 to 5 years down the road as to your technology. You need to be talking to your vendor, especially on the hospitals. You have a long lead time to get your updates in place. You want to be absolutely making sure that you know where the vendor's headed and what their timeline is, because what you'll see is that as we start adopting Stage 3 in 2017, that 2017 is a soft period, and you can go different ways in how you do your attestation. The second reason you want to consider this rule is because there are so many unanswered questions. And Dottie will be sending you, besides just the slides, she's sending you the rule itself, the policy rule. There's two rules, policy and certification, and with a cross-reference to the pages where CMS has asked for input and comments. The reason this is important is there are so many unanswered questions in the rule about how this is all going to flow together, especially with new technologies. And so we really do need the input of you IT people, of your policy people, and you people who work with meaningful use at the practice level, because that's where CMS is going to shape this ultimate policy. And with it being a proposed rule, the final draft most likely will not be out, I'm going to guess, September of this year, which means that it coincides with the start of the 2016 reporting period for hospitals. So you don't have a lot of time to plan. You want to pay attention to how these rules are being developed so you know how to continue your discussion with your vendors. If you decide you want to comment on the rules, if there's something that really bothers you or that you feel isn't clear, you can either send your information in via email to this email site, or you can mail it in. And in either case, you're welcome to send them in directly, or if you're interested in joining us in a consolidated response talking about what's going on in the state of Ohio, please feel free to contact Scott or me, and we will get back to you and let you know what the proposal is going to look like as far as the response from the state level. Okay, and with that, let's get going and see where we actually are with meaningful use and what's in these regs. This reg obviously goes to the stage 3. Stage 1 was adoption, stage 2 was interoperability, and stage 3 is improvement of quality and public health. I think it's fair to say that the stage 2, which we're still in, has a lot that's still being developed. And so as we look ahead to stage 3, it's that blend between stage 2 and stage 3 that we're still trying to strike the balance with CMS. Here are the actual proposals as to how stage 3 would roll into the meaningful use world. Stage 2 right now is the technical period we're in, 2014 to 2016. Whether or not you're actually attesting to stage 2, it's considered to be the stage 2 period, with core and menu measures and CQMs all part of the mix. In 2017, we undergo a transition period where CMS is calling it another flex year, but it's not flex year like 2014 was flex year. It's flex year meaning that you can select what stage you're going to attest to, stage 1, stage 2, or stage 3, but it is decided by what your 2016 attestation was. So if you were attesting for stage 1 in 2016, you're welcome to attest to stage 1 in 2017. If you were attesting to stage 2 in 2016, you don't have the option of rolling back to stage 1. You either attest to stage 2 or stage 3. So it's a little bit different way of looking at it, but you're going to be driven really on two areas and questions. How is your vendor responding, and how quickly can they get you the upgrades that move into stage 3? And then the second one is, how ready are you as an organization or a practice to adopt those new measures? A lot of the measures reflect what you're doing in stage 2 as far as workflow, but not all of them. There are several brand new areas that you're going to have to consider how you're to adopt them technically and how you're to establish your workflow. When we're in stage 3, which is 2018, is the official opening of stage 3, everyone, doesn't matter who you are going to attest to stage 3. And that is what has always been the issue in the past, is you might have providers at stage 1, year 1, stage 1, year 2, stage 2, year 1, and it's been very difficult to track. In 2018, everybody will be at stage 3. And we'll talk a little bit more about the core and menu and CQMs in the next few slides. Now, on the hospital side for stage 3, well, within the stage 3 reg, it's not, it affects timing. The reg spells out the fact that the shift that hospitals have been told is going to occur, where hospitals currently who report on federal fiscal year from October through September of the following year are going to move into a calendar year reporting, so they mimic what's going on with the EP's reporting. This should make it easier for everyone to track at the same time, but it does raise issues as to when this is all going to occur. Under the stage 3 proposed regs, that shift for the hospitals is going to be after your 2016 reporting period. So you would report in 2016 from October of this year, 2015, through September of 2016, with what CMS is calling a non-reporting quarter or reporting gap in October, November, and December of 2016. I know that CMS has mentioned this publicly, and some people believe that shift is going to occur this year, but until we see those 2015 regs, All I can tell you is what's in the Stage 3 regs, and that is that the hospitals will shift at the end of their 2016 reporting period. If that changes under the proposed 2015 regs, we certainly will let the hospitals know as quickly as possible. On the physician or EP side, everyone stays on the calendar year reporting. The difference, though, in 2017, you start picking up some differences from your current reporting. Starting in 2017, all EPs will report for a full year, unlike the current proposal where you report for only 90 days if it is your first year of reporting. The only exception, and very narrow exception, is if you are a new EP reporting under Medicaid. Everybody else is going to report for a full year, even if it is your first year of reporting. Another huge difference going into Stage 3 is all functionality will need to be electronic, and we'll look at that more in depth in a minute. The Stage 3 attestation is going to look different than what you've seen in Stage 2. In Stage 1 and Stage 2, the meaningful use process involved core and menu measures where everyone had to report on the core and you selected the menu. This will no longer be true for Stage 3. At Stage 3, there are 8 reporting areas, what CMS refers to as flexible measures. And in some of those areas, you may have 2 or 3 different measures attached to that area. So I cannot tell you that there are only 8 measures. There are only 8 categories, and of those, there are a number of measures under many of them. As I said, all reporting will be for 1 year. The CQM area, now this is interesting, and for those of you we've worked with on quality stuff, you know this is a huge, huge area. And the hospitals especially, a heads up to you all, because we all know that there were huge problems with CQM reporting in 2014. Not necessarily the vendor's fault, because the 2012 measures that they were mapping to for Stage 2 had so many problems when the CQMs were released that the vendors, many of the vendors did not get accurate CQM reports for under the 2014 certification. So that's still being corrected for a lot of people. We know a lot of hospitals that are still doing chart abstractions rather than running that directly off of their CQM reports. But starting in 2018, whether you're a hospital, whether you're a physician, whether you're another EP, you will have to report your CQMs electronically. So eCQM. So you want to be working with your vendor to make sure that any bugs are out of your CQM reports, because it'll be much more difficult to correct those going forward. The other thing that you need to consider when you're doing your vendor discussions over the next several months is you have to have 2015 edition, which is what they're calling the latest round. So we had 2011 certification, 2014 certification. Now this is, the Stage 3 is going to be, rather than calling it 2015 certification, CMS is calling it 2015 edition. So you need to have that 2015 edition EHR in place no later than the beginning of January of 2018. So that is your last chance. If you decide to use Stage 3 for your 2017 reporting period, you need to have that technology in place January 1st of 2017. So consider your timelines when you're mapping out your technology over the next couple of years and your clinical workflows. Make sure that you keep that in mind, that these are the deadlines that you're working against. Please note, many of you are in the process of attesting for the last time, or maybe in 2016 for the last time, under meaningful use as it pertains to receiving incentives. It does not matter moving forward whether you are still drawing down incentives or not. You are going to be required to attest to meaningful use to avoid the penalties, which will be significant the longer we're in the process. The updates to CQMs, and this is interesting point because CQMs are really the heart and soul of stage 3 moving forward. The quality reporting are no longer going to be reported, and you will not see much of a discussion about CQMs in stage 3. The reason this is so is that CMS is moving all the guidelines and all the measures out of a meaningful use structure and into the physician fee schedule rule that is released every fall for the physicians, and the IPPS hospital rule that comes in, I think it's usually around April or May. And those rules are going to be the vehicle to discuss any changes in the CQM program and any changes in the reporting. Not clear, it was not enunciated in the stage 3 regs, whether or not you are going to have to continue to attest to CQMs as part of meaningful use, or whether all your CQM reporting will move into PQRS and the IQR program for the hospitals. That remains an open question, but either way, you will be tracking CQMs. Okay, I'm going to turn it over to Scott to run through some of the new terminology.
Before I get started, I just want to apologize in advance if you hear any thunder or any noise in the background. We are having a pretty good storm here in Columbus. If by chance that we do have a power flicker and we lose our connection, we will just, fire everything right up, wait a minute or two, and then start again. So I just wanted to update everybody on that in case you hear some background noise. Well, anyway, in both the Stage 3 and certification criteria proposed rules, CMS added some new terminology, and they modified some other current terminology to with the goal of broadening the scope beyond the acute and ambulatory settings and to align with the interoperability roadmap. These new terms and updated terms include the Common Clinical Data Set, the API or Application Programming Interface, and you programmers and techie types are pretty familiar with this term. Patient Authorized Representative, and you'll see this later when we start talking about the patient portal measures. Clinical Information Reconciliation. Again, this will be around the electronic transitions of care. You'll hear this term. And our good friend Clinically Relevant Information is back, but this time with respect to customizing the clinical summaries. Now we're going to go in depth with each of these terms a little bit more throughout the presentation. Well, some of the measures have been removed in Stage 3, just really meaning that they aren't tracked for reporting reasons, but in many cases these are still underlying critical data elements for other measures such as your transition to care CQM. CMS also removed measures that have topped out because they're generally reported at high levels across all providers, and these related workflows have become really ingrained into all the practices. So these measures are no longer going to be reported to lessen the burden on the providers. For example, the demographics measure has topped out. You'll no longer need to report on the gathering of demographics data. Now, keep in mind, demographics is a critical element. You still want to make sure that everyone is collecting that information. The medications, medication allergies, vital signs, and smoking are now considered to be duplicate measures because they're required elements within the transition of care document. So if any of these items are missing, it would be a hit against your transition of care measures. These data points and the ability to report on these measures are still part of the certification criteria. So even though you aren't going to be reporting on demographics, a Stage 3 certified system will still be able to generate a report on your demographics measures. So if you no longer collect these data points, you will not meet meaningful use. You will not meet the TOC measures, and your CQM measures are going to be extremely low. So it's critical that you continue to collect these data points. Also, in Stage 3, CMS is proposing removing the reporting of paper-based measures where something is printed out and handed to the patient. In Stage 3, we'll focus purely on the electronic transactions. So the clinical summary, the printed patient ed, and the printed transition of care measures no longer exist. However, the proposed rule clearly states that providers should give patients education and information in a format most relevant to the patient and easy easiest for the patient to understand. So really, you still want to be printing this information and handing it to the patient. You just won't be tracked.
Right, and keep in mind on this measure, since a lot of times I know practices, like especially if they're in a specialty area, may have their own information that they want to hand out to the patient. There is nothing wrong with that. But what this new reg says is basically, I know some of the vendors created a button where you could hit it and say that you were handing out information that was coming from outside of the EHR. That's no longer going to be allowed. The info button that provides the patient education is really going to drive this measure. So if you do hand out, you still are going to have to go through your EHR to collect additional patient education to have it count.
As Cathy shared earlier, the concept of core and menu measures does not exist in stage 3. What they've done is they have 8 object groups, and within each of the 8 object groups are multiple measures. Sometimes there's 3, in a few cases there's more than 3. Some of them are meet 2 of 3, some of them you have to meet all 3 of the measures. We're going to go into a little more detail on each of the objective groups. The first objective group only has one measure, and it's the protect patient health information, and it is the first objective for a good reason. CMS views HIPAA compliance and protecting patient health information as the highest priority item for all of their programs. This objective states that the provider or hospital must conduct a security risk analysis that assesses the risks and vulnerabilities of the electronic patient health information and the related systems. The lack of a sufficient security review remains the #1 reason for a failed audit. So there really isn't much difference in this proposed rule from the stage 2 patient health information, protect patient health information measure, but we're going to take a little deeper dive. You know, your security review should assess the technical, administrative, and physical safeguards. You may notice that this terminology aligns closely with the SRA tool, or the Security Risk Analysis tool from CMS, that many sites have used to complete this required review. Keep in mind that your technical safeguards, they are critical, but they in and of themselves are not enough to protect electronic patient health information. Your technical safeguards, of course, include your firewalls, audit logging, virus scanning, and other IT tools or systems. You know, this should be part of your review. Also, you need to take a look at your administrative safeguards, which are your risk analysis, your risk management plan, your HIPAA training for your staff, and your contingency planning. You must also review your physical safeguards, which include the access control or the locking of your buildings or rooms within your building, screen protectors on your workstations, your device media control, and other aspects of your physical safeguards. Now, the review that's required by meaningful use is more limited than HIPAA. It focused solely on the safeguards and processes and controls for your EHR, your portal, and the related modules. Now, the protecting of patient health information should not be treated as a point-in-time event, but an ongoing process. As demonstrated by this graphic, you should perform the review, then identify your risks and develop your remediation plan, and then you should work towards correcting those identified issues, and then the whole process really starts all over again. At each step, you really need to document what you're doing within that step of the process, because you're going to need that information if you are audited. You've got to perform the review every year. You should also perform it when you have a significant upgrade or change within your environment, and always perform a security review anytime you have a security event or a near miss. I'm going to turn it back over to Cathy to talk about prescribing.
Okay, we're going to run into the next 3 measures are e-prescribing, clinical decision support, and CPOE, followed by 2 of the patient-facing measures, the HIE, and then public health. As far as e-prescribing, we're not getting into a great deal of discussion on percentages. You can review that and decide how realistic they are, but let's look at the changes in how you capture. With the hospitals, notice that there is a change in which medications are included, in the sense that you do not count refills of prescriptions that were originally prescribed out in the ambulatory setting by their family physician or whatever. You are only going to count new or changed prescriptions that occurred during the course of stay where the patient was within the hospital. And all prescriptions need to be queried for the drug formulary and then transmitted electronically. Let's look at some of the specifics here. There is a move, and you'll be hearing a lot more about this in the next few weeks, to do controlled substances e-prescribing. There's a lot of different technology, or not technology, but checks and balances for that you'll be told about how to do it within Ohio. But as far as meaningful use goes, if you do begin your controlled substances e-prescribing, you can include those prescriptions within your e-prescribing numbers, but you are not required to. So it's really left up to each individual practitioner as to how they're going to count e-prescribing of controlled substances. Over-the-counter medications are not included. Another interesting thing about the certification standards for e-prescribing is a SIG field, which is the free text field on prescriptions, has been expanded and structured. What is currently within the vendor systems is 140 characters goes into a SIG field to explain dosage or different information about the use. That has been a problem historically for a lot of cases, because it would cut off if the physician wrote directions that took more than 140 characters. So under the new regs, they have upped the SIG field to 1,000 characters, and they're going to make that field more structured. So hopefully this will address some of the ongoing e-prescribe issues that have occurred over the past several years, and will make it a smoother process for your prescribers. The other thing to keep in mind, and I think a lot of people will applaud this, under the new certification standards, the e-prescribing feed has to be bidirectional. This has been, again, a problem between practitioners and pharmacies, because as the practitioners started sending the prescriptions through e-prescribing, if there was any question about it, the pharmacist did not have the ability to email the practice back. They had to pick up the phone and call them or fax them for further directions. Under the new certification standards, that e-prescribe connection has to be bidirectional so that the pharmacist can communicate with the practice. The other thing about the bidirectional capability is to allow practices to be notified if, in fact, a patient has had the prescription filled and picked up. So how that is actually going to work is not really fleshed out in the rules, but the technical capability is part of the e-prescribing certification. Next area, clinical decision support. In this area, there is not a whole lot of change from stage 2, at least as it was redefined in the middle of 2014. So as we began stage 2, you had the 5-4-3 rule. You had to have 5 clinical decision support rules in place to support 4 clinical quality measures that you were tracking over 3 domains. The stage 3 rules talk about the 5 and the 4. They still have 5 CDS tracking back to 4 CQMs. No discussion of the domains. That will be something that will be addressed, I'm sure, in those ongoing updates of CQMs. The other thing about this, and the change that we saw in mid-2014, is CMS moved away from the idea that a clinical decision support rule was only built-in pop-ups within the EHR system. The definition was expanded to include not standing orders, but order sets and common things that are used by hospitals and by physicians to remind them of, for example, a chronic care management. Diabetes patient comes in and you have an order set that tracks to working with the diabetic. That can be considered a clinical decision support rule. CPOE, kind of the second part of ePrescribe. As you know, at stage 2, CPOE expanded to 3 measures. It went from just being medication orders to include lab orders and radiology orders. What you will see now, besides increasing the percent, the medication and lab stays the same language-wise, but the radiology term is now expanded to include all diagnostic imaging and not just x-rays. So this will include the tracking of ultrasounds, CAT scans, MRIs, and any other diagnostic imaging that is used. This is an area that Scott and I have had a lot of discussions with practices and with hospitals over the past several years, and that is who can enter under CPOE. We know that any healthcare professional that's licensed can do that. We know that credentialed medical assistants can do that. The question became, could people like radiology techs enter radiology order? And these rules say yes. They expand that definition to say that a medical staff member who is properly credentialed and performing equivalent duties to a credentialed medical assistant can also enter information under CPOE. But the one thing that the reg makes clear is that CMS is deferring to the provider's discretion to determine the appropriateness of that medical staff member entering that information, because you want to have someone who knows enough about the system and knows enough about the order entry to react if there's a pop-up. So it's our recommendation, both not just for audit purposes, but really for your own internal workflow, to take a few minutes and just write out a paragraph that explains who within your office or within your hospital has the right to do CPOE and how it is being utilized. Okay, and the CPOE specifically is called out in the stage 3 regs to say that paper orders initially entered into their record and then transferred to the EHR system do not meet CPOE. Orders that are non-compliant with the EHR definition and then entered at a later point in time does not meet CPOE. And protocol or scanning orders may be excluded from the CPOE calculation. So that's really up to the individual institution on how they handle scanning orders. Okay.
Alrighty. Now we're going to talk about the patient electronic access to health information objective. This is really the first of several patient portal measures. This objective states that providers and hospitals must provide patient portal or API access for patients to access their health information. There are 2 measures in this objective, and right now the proposal says you have to meet both measures to meet the objective. Measure 1 states that for more than 80% of your unique patients, you must provide access to their health information within 24 hours of availability through the portal or through an API or third-party application or device. Now, note that this is down from the 36 hours for eligible hospitals and 3 days for physicians. So the time to review documents before they're sent over to the portal has been dramatically reduced. Also, the measure is written in such a way that it alludes to more discrete data items being shared with the patient. And, this is really due to the clinical summary going away. Measures 2 states that the EHR is utilized to identify patient-specific education and to provide those resources electronically to the patient for more than 35% of your unique patients. The electronic access to patient information is really going to be done through integration with the info button or the blue button or some other online electronic resource. So your patient education is going to have to be pushed to the portal or to the API, either the educational material or a link to it. Now, within this portion of the proposed rule, they talk a lot about the patient authorized representative. Because a patient authorized rep should be included in the numerator and denominator. And since they did this since patients often consult with or they rely on a family member or a trusted caregiver to help understand their health information. So stage 3 rules provide an avenue to count these patient-authorized reps. And again, they are supposed to, they're expected to act on the patient's behalf and in their best interest. So hospitals and physicians must provide access in accordance with applicable laws to make sure that you have the power of attorney or the relationship to the patient documented somewhere in your EHR. The concept of the patient authorized representative applies to both the portal and the API. Now, in the proposed rule, the data has to be released to the patient portal or API within 24 hours of availability. Since the hold time on results and documents to allow for a provider review is going to be limited, you're probably going to need to rely more on triggers or thresholds to block information passing to the portal that you may want to contact the patient about first. Also, whether the patient or their representative accesses the data through the portal or through the API, both of those should count towards your numerator and your denominator.
Yeah, and something to keep in mind here, just to kind of bring it down to a non-techie level, is that basically what CMS is saying here, and this is one of those areas that you may want to comment on because it is not settled in the rule. CMS is saying, okay, we know that everybody was required to put a portal in place in 2014, but we're trying to react to the new technology, which is this ability. We all know what the problem with the portals were. And the problem is that if a patient sees more than one physician or goes to more than one hospital, they may have access to 5 or 6 different portals, and there's no unanimity or one point of access. And so CMS in this proposal is saying, hey, let's propose something that allows these APIs, which is basically a vendor who works with the EHR vendors and sweeps information from various EHR systems and consolidates it into one point with the patient as the controlling person as opposed to the practice or the hospital. So on the left-hand side, you have your patient portal, which you already have up and going. You understand the control issue is on your side, and you push the information to the portal. On the right-hand side, the control rests with the patient and with this API vendor who sweeps through any group or organizations that have signed up through their EHR vendor to be party to this, and they sweep information out of the EHR system for that patient's information. You know, there are a lot of open issues.
Yeah.
Scott and I have looked at that a number of times, and I'm sure you kind of feel the same way. I think I hear you all gulping.
Yeah.
And I mean, and really, it's just an enormous question. Is how, do you have any control over what pushes to the API? Or is every single thing that is in that patient's record, all the notes and everything else, going to push? We don't know.
Yeah, and in this section of the proposed rule, they talk a lot about the PHRs, the personal health records, as as one example of how you use an API. Now we're going to talk a little bit more about APIs. As you got techie types out there know, an API is a set of standardized programming protocols that allow an application developed by a third party other than your EHR vendor to access data stored within your EHR. Now, within the proposed rule, there's talk about the API having access to a limited set of data or to the entire common clinical data set. The good side of APIs is they can be more flexible than your patient portal because they allow for data to be accessed from multiple platforms like tablets, smartphones, or even certain devices. So when I think APIs in this context, I think like weight management applications, hypertension management applications, diabetic applications that could be ran on a smartphone or some device, and then pull information from your EHR. So there is a lot of potential. But like with the portal, the provider would have to provide information to the patient on how to access the API.
Yeah, and again, just to keep in mind where the reg is on this point, that is one of the unanswered questions, whether or not you can use either a patient portal or an API, or whether you'll be required, technologically speaking, to make both available. So clearly that is something, if you feel like commenting, you may want to look at more carefully.
Yeah, I would say the discussion of APIs takes up more space in the proposed rule than any other discussion. Now, there are going to be some challenges with the API. From a programmatic standpoint, it's going to be interesting to see how the vendors track numerators and denominators. And I know if you guys have any background in security, you've got a huge red flag thinking there's going to be issues with APIs because, in other sectors, APIs tend to be the glaring hole in security issues. So again, as Cathy said, CMS is requesting comments about API, if it can replace the portal, how it can be used. So by all means, if you have comments about it and you don't want to take the time to post them through the standard means, send them to Cathy and I, and we'll include them. And I'll turn it back over to Cathy.
Yeah, and the second patient-facing area is this coordination of care through patient engagement, which has all of your favorite measures rolled up in it. The first one is view, download, and transmit. Stop cursing, everyone. The second one is even the more hated secure messaging. And the third one is related to this new area, totally new area, and that is drawing in information from a patient or a non-clinical setting. Let's start with the view, download, and transmit. You thought it was difficult to meet 5%. Wait until you have to meet 25% under the new Stage 3 regs. The reason I think this has occurred, let's go back for a second. Look at the top of the dark purple part of this slide. This is an optional. This is meet 2 out of 3. Report on all 3, but you have to meet the threshold for 2 out of 3. And so CMS is, in this case, is trying to react to what were some very heavy criticisms of the patient-facing measures. But the issue that I see is that I am not sure that every practice and every hospital is going to be eligible to work under all 3 measures. So I'm not sure how optional it will be, and we'll talk about that in a minute. But as it pertains to the way that it is written now, the view, download, and transmit would move from 5% to 25% for both hospitals and physicians. Hospitals, as Scott had mentioned in the previous discussion, have moved away from posting of a clinical summary within 36 hours of discharge to posting whatever is available within 24 hours of availability. The EPs move from a 4 business days of availability. So say your labs come in from the hospital and you have 4 days to review it before it posts to the portal, so you can call the patient if you want. Now it's you have to post within 24 hours. So it creates almost a default of where all the information flows through. And the CMS, again, knows that there's issues here, and they're asking how you would calculate the patient viewing issue if, in fact, they require use of the API, is how you would calculate that. The second option in this area is secure messaging. As we said, it had to have been the number one measure that, oh my gosh, I can't tell you, and for all of you who are on the phone that we worked with, you know what we're talking about. On January 29th, 30th, and 31st, posting people sitting in the lobby of physicians' offices trying to meet 5% of the patient view, not just view, download, and transmit, but sending that secure message email back. And so I don't know if Ohio's particularly slow, if we just know that we've had a lot of problems and the rest of the country is zipping through this, but for whatever reason, it just was an extraordinary problem around the state. So the way that CMS responds to this, and I do think it does make a lot more sense, is rather than calculating every time the patient contacts you, it turns around. And it's every time you, the practice, or the hospital contact the patient. That is what is being captured there. And I think the percentage was 35%. But it's the issue is here, there's a couple of things that kind of concern me about it, and so I want you to think about it, is for the most part, hospitals do not normally email patients as follow-ups. And that is one reason why the secure messaging measure didn't show up in the hospital measures at stage 2. It was only a physician EP measure. And that is because ongoing care usually transfers back to the provider. So how much will the hospital be able to utilize this measure is a question. Clearly, if you go to a new business structure where you're using a nurse navigator, or you're part of an ACO structure where you're doing a lot of external follow-up, that may be one thing that you can use to meet this measure, but there are a lot of questions. The other thing to keep in mind about this measure that you may want to think about the impact of this is that you can use the measure to send emails out to other specialists, providers, to communicate with them about a patient's care and count that, but it only counts if you copy the patient on that email. And this is something as a workflow matter that I don't think a lot of practices or hospitals would do normally, is copy the patient on all that information. But as I said, this is just something you have to think about.
Well, and also our good friend clinically relevant comes back in the secure messaging measure, because you cannot count a message that is an appointment reminder or that's about billing. So for those few EHR vendors out there that build that met the secure messaging measure because they sent out this appointment reminder that had a yes/no button that flowed back in through the secure message in the portal, those don't count. It has to be something clinical in nature. So it'll be really interesting to see how EHR vendors can write a report to determine what's clinically relevant.
Yeah, you got that right. But the last thing to keep on this is CMS hasn't really figured out how to calculate who all's included in the secure messaging, because they don't know if they just want to copy or let the person who sends the email use it in their numerator, or whether the person is receiving it, if they're another provider, they too can participate.
And also one other thing to keep in mind is this objective is a meet 2 of 3 of the measures. Right. So you don't have to meet all 3 measures, but any measure or any objective where you only have to meet 2 or 3, you still have to report on all 3.
Okay, now this third area, again, this is like a big red flag area in the sense of brand new. I want you to think about what it's saying, because it represents both new technology, new challenges, new opportunities. What CMS did here, since stage 3 is their last meaningful use reg, they rolled up a lot of what they wanted to do policy-wise and initiative-wise. So if you look on this slide, the patient-generated health data includes categories from either or both of these areas: information received from a non-clinical setting and information received from the patient. The problem is that CMS did not do a very good job of defining these categories, because on the left-hand side, information received from a non-clinical setting includes many, many, many clinical sites in it. And the way they backed into this definition is they said information that falls within this measure is information that is generated by anybody other than an EP or an EH. So if it's someone other than a physician, other than a hospital, you can count it. But look at the number of people who are included as examples. This isn't a complete list, but it's everything that was in the reg. Nutritionists, physical therapists, occupational therapists, psychologists, home health providers. A huge, huge category of what they're expecting to flow back in through into your EHR from these, quote, non-clinical settings.
Yeah, and another thing I find interesting about that list of non-clinical providers is many of those providers are outpatient departments of many hospitals. So it'll be interesting to see how they allow that to flow and count.
I can see many FAQs coming in this area. But, okay, on the right-hand side, this goes back to what Scott was mentioning. This is kind of like the Fitbit. We've been demoing some of this patient chronic care management technology. You know, all this stuff where it may be information on weight, blood pressure, glucometer information, all these various things that can now be electronically transmitted, calibrated, sent in electronically, is what they're raising on the right-hand side, and that would be generated either by the patient on their own or under the direction of a care team member. So this could be vital signs, activity and exercise, medication intake, nutrition, but look at the bottom. Here are some of the examples that CMS gives of what would be included in this data set. Social service data, so information about, Meals on Wheels or something like that. Advanced directives, not normally a structured area, not sure how that's captured. Medical device data, fitness monitoring. So this is kind of a catch-all measure. CMS is not sure how they're going to define all of this. They just know what they want to capture, and that is to allow practitioners to capture information from the outside and put it into their medical record, but they are not sure where they're striking the balance between actually structured data and non-structured data. Is it going to count if it comes through a structured feed from the patient's blood pressure cuff, or is it going to count if the patient calls you and says, hey doc, I weigh 5 pounds more, my blood pressure's a little bit up, but I'll take it again. Who makes sure that stuff's calibrated and what counts? So that's all stuff that are issues here.
All right. With respect to the health information exchange objective, CMS has really stepped it up again here as well. Within this objective, there are 3 total measures, and you only have to meet 2 of 3. So let's talk about the first measure. The first measure is the transition of care. Previously, your electronic transitions of care were 10%. I think CMS has a fascination with factors of 5. Because the BDT goes from 5 to 25, your electronic TOCs go from 10% to 50. The printed transition to care don't count, they don't track them. So with this measure, it's all about creating the transition to care from within your EHR and sending it from within your EHR. Now, one thing that they do is they more clearly define the definition of a transition of care. On the hospital side, it's every discharge from inpatient. So if you send a patient out the door, that's a transition of care. They also include every ED discharge where follow-up with a primary care provider or another provider has been ordered. So to meet this higher threshold, you really need to start now with engaging healthcare providers in your area to join the HIE. We're working really hard to get the post-acute care sector engaged. We've had a lot of luck here recently, but we really need the hospital and the provider's assistance with getting more and more folks engaged. Now, we've mentioned a couple times the Common Clinical Data Set. This is a new term introduced in Stage 3, and this really replaces the Common Meaningful Use Data Set. But it does include additional elements like the Unique Device Identifier, or UDI, for implantable devices. Your immunizations are now included, but they also include the NDC and the CBX code, and there's a couple other data points that they're including as well. Another thing they're doing in the certification criteria is updating all of the vocabulary codes for the various data elements that are stored in your EHR. We're going to talk about those real quick here in the next slide. Another thing that they've done with the Common Clinical Data Set is they've taken that care plan field and they've replaced it with 3 separate fields for 2 reasons: to eliminate some confusion and also to meet the new requirements of the CCDA 2.0 standard. The care plan field's been split into assessment and plan of treatment, goals, and health concerns. Now, another thing that you're going to see with the electronic transitions of care is that anytime you send a TOC, it's actually going to send now 2 files. Before it sent a CCDA. Well, now it's going to send a CCDA in the 1.1 standard and in the 2.0 standard. So that way the receiving system, if it's a system that's not a Stage 3 certified system, it would only be able to consume the CCDA in the 1.1 standard. Now let's take a quick look at the updates to the different vocabulary codes. You'll see that HL7V3 for the sex, the CDC codes for the PFIN, BADS for the race and ethnicity, which is about 900 codes. They're going to LOINC 2.5. Something I thought was interesting was for the vital signs, they're now going to, behind the scenes, be coded with LOINC and the relevant UCUM unit of measure. So this is included. You guys will get a copy of this slide deck. Now, there are a minimum set of required elements to be included in the common clinical data set, which then would flow over to your CCDA. Those are demographics, current problems, current meds, current med allergies. If you notice, that corresponds exactly with the measures that are no longer being tracked. If those don't appear, your CCDA doesn't count. All the other fields can be left blank if information is not available and still meet this requirement. But what they are doing is they're allowing some flexibility for you to include what is clinically relevant in the CCDA. Because, you know, if you have a patient that has a long hospital stay, those CCDA documents can be, you know, 70, 80 pages, so that the provider receiving that, you know, they're going to look through it and they just kind of get lost. They can't find the information easily. Well, now you can eliminate those hourly blood gases that have no clinical relevance after the patient's been discharged. You can leave all that stuff out and just include what is truly clinically relevant for the next provider of care. So let's take a closer look at measure option 1 for this objective, the sending of TOCs electronically. CMS has clarified some language around what constitutes a transition of care in that providers under a different billing identity but that have access to the same EHR can still count as a transition. You know, if you've worked with Cathy and I, you know, we've had discussions for health systems that have a physician group in a hospital, and it was always, the standard always was if you didn't have full read access to the EHR and they were different billing identities, well, then that can count. Well, now, if you're using a combined system, as long as the provider is under a different billing ID, the transition of care counts. But it will be interesting to see if they actually go through the process of sending that TOC, since it's going to be created from data within the same system that they're looking on. So it'll be interesting to see what they do with that. And again, providers have the flexibility to include only data that's clinically relevant. And one thing about the CCDA 2.0, it does support data segmentation and embedded rights such that protected information can be included and only accessed by a receiver with the sufficient rights access. So think behavioral health.
Behavioral health is a huge area for this.
So behavioral health information could be included in a CCDA, and if the receiving provider doesn't have the rights to access that portion of the CCDA, they just won't be able to see that information.
Okay, let's look at the second option here, and that is for 40% of transitions or referrals. If you have never before encountered the patient, you incorporate into your EHR a summary of care from another source. Or if not from another source, that you query from the HIE for that patient's record.
Yeah, I felt that this measure kind of closes the loophole in stage 2 that where providers had to send a transition of care, but within stage 2 they didn't necessarily have to receive one. So I was kind of happy to see this measure.
Yeah, so this one has several issues on how it's interpreted and what do they mean by a new patient. CMS does not explain that. Is there a timeline? Is there, you know, what was the preceding referral pattern or the patient being seen during that time? And then the query function is going to be a big issue as we open the health record, the community health record across the state. This can work into this whole process of meaningful use, but if no record is found, then you just don't count that patient in the denominator. And the summary of care document must be ingested into your EHR. You must incorporate some of the parts to it and not just view it. And again, here are the issues that we had raised that CMS has asked for clarification on. The third option here under Health Information Exchange moves us away from the idea of doing a med reconciliation, which was part of Stage 1 and Stage 2, into what's called a clinical information reconciliation. And this has three parts: med allergy, and current problem list. And so think about when you have a new patient come into your practice or into the hospital, rather than just asking them about their med list or reviewing it with them, you not only have to incorporate now medication, med allergies, and the current problem list. And the reason it says current problem list is because the reg steps back from saying how much has to be in that current problem list. Since they are going to allow you to customize the clinical summary and the CCDA fields, which we all know is a real problem at Stage 1 and Stage 2, then you may have more streamlined information that you both receive and ask for. And so your review under this clinical information reconciliation may be more focused depending on your specialty or depending on the circumstances. So CMS is seeking comment in this area to find out whether this reconciliation is automatic from the clinical summary that you receive, or whether you can manually review it and then check it off in your system. All right, now the last area, I think public health is the last area, is an expanded area that has 6 parts to it, but really when you look at how it's summarized, you'll see that it's not really quite as extensive as you would appear. And probably the easiest thing to do is to look at this chart, and I'll have Scott walk you through that.
Yeah, the way this rule is set up is that there are 6 measures within the objective. The eligible providers will choose from measures 1 through 5, and they could attest to any combination of 3 measures. And the eligible hospitals will choose from measures 1 through 6 and attest to any combination of 4. Now, the nice thing about this measure, the way it's laid out, is some measures can be counted multiple times. Of course, you still have your immunization and your syndromic measures. Those can only count once. But when you get down to measure 4, the public health registry reporting, EPs could count that a maximum of 3 times. So if there are 3 different public health registries that you report to, you wouldn't necessarily have to do immunization or syndromic, and the same with the hospitals that you can do 4.
Yeah, so this is like your cancer registry that was individually called out at Stage 2, but at Stage 3, CMS just wasn't into listing all the options because not every state could accept all, and every practitioner was not interested or like, for example, doing immunizations.
Yeah, and as you look, there's really not a lot of depth of information for like Measure 4 and 5, Public Health Registry and the Clinical Data Registry. They talk a little bit about them, but I believe you'll find that these reporting tools they overlap with some other initiatives within your organization. So talk to your quality team, and I'll bet the Clinical Data Registry reporting, they're probably already doing it. Well, now you can count that towards meeting.
Yeah, so basically the way this is expanded is up at Stage 1 and Stage 2, you were doing only public health reporting under this measure. At Stage 3, you can continue to include everything that you're doing for public health reporting, especially if you're already built and sending it, but you also can include private registries. So if you're a specialist and you're reporting to, say you're an orthopod, and you're reporting up to the national level for your statistics on your quality measures, that would count. But what CMS is going to do between now and the time the Stage 3 opens is they want to pull together a listing of all the registries that can be recognized in the country. So that should help you all in your discussion with your quality team.
Now, some other things to keep in mind with public health registries is exclusions don't count. The only way you could count on exclusions is if you're able to show that you'd be excluded from everything else, kind of like the old menu measure exclusion. And the term ongoing submission is replaced with active engagement, because really, when you think back to Stage 2, the spec does say you have to have ongoing submission, but what that really means is to be registered or to be testing and validating. Well, active engagement probably is a better term that encompasses that.
Yeah, and created less angst. There were, I mean, I can't tell you the number of problems ODH and Medicaid and everybody had over the interpretation of this term, because they're trying to explain to practitioners that they were fine if they were registered or they were working on testing. And so this is just CMS's way of making clear that you can be in the process and still meet the measure.
Now, we did include a slide for each one of the public health or clinical data registry measures, but we're going to skip over them. They will be included in the slide deck that all the attendees will receive.
Okay. Now we're going to zero in on clinical quality measures, because this continues to be and probably increases in importance at stage 3. To again remind you that electronic submission of CQMs is optional in 2017 but required in 2018. CMS has not specified under the stage 3 regs how many CQMs you will need to attest to in 2018. That will be spelled out in the physician fee schedule or IQR rule. It does require vendors to be certified. Stage 3 is going to require them to be certified for more than the minimum 9 measures, and this is to address the problem that we saw at stage 2, where vendors were only going with the minimum and were leaving many specialists in the dust as far as their ability to report on measures. And for the hospitals, your full year reporting will consist of the 4 quarterly data reporting periods.
The one thing to watch here for here with respect to CQMs is that the move to a full year reporting will allow finally for the alignment of CQM reporting with PQRS. So I can really, my hope is that you will now really only have to report once.
Yeah, we won't know until they spell that out, but that was the goal. They mentioned it at stage 2 several times. It just hasn't happened yet because the reporting period has been less than a year. But I think we may well see CQM reporting totally dropping out of the meaningful use picture and being replaced strictly by PQRS and IQR reporting.
Okay, we're going to talk about some modification to the certification program, which is all specified within the certification criteria rule that was released. We're going to go through these real quick. The certified EHR technology term is being discontinued. They're replacing that really with the the ONC Health IT certification, so that the certifications can apply to what is not traditionally considered an EHR. The base EHR is really replacing the term complete EHR. A base EHR has to include, at a minimum, all the functionality necessary to meet stage 3. Now, there's a lot of other functionality discussed in the certification criteria, some stuff with data portability and the ability to import CQM information from other EHRs. Those will not be required for a base EHR. It's just everything you need to meet and report on stage 3. One thing that I am kind of excited about is that the authorized certification bodies are expanding the testing and reporting. Well, ONC is going to require them to do that. And this is to overcome some of the shortcomings in the current EHR certification program. And this has been needed for a long time. The goal of this change will be to provide meaningful disclosures of issues and limitations of EHRs that could interfere with the ability to implement the EHR in a manner consistent with the certification. The ONC authorized certification bodies will now be required to report EHR complaints up to the ONC. They must perform in-the-field surveillance to ensure that the implementation can be repeated and be successful in the wild or in various production environments, and that they only can't be done in a sandbox or protected environment like they had to for previous certification. The in-the-field surveillance is going to be reactive and random, so if they start getting complaints about a particular EHR vendor, they're going to have to go out and check things out. And then also they have to do a minimum number of random audits. All the information that's collected, including performance data, will be shared on the chapel website. If issues are found, a vendor is going to be given a certain set of time to respond with an action plan. If they do not respond, they aren't able to meet the plan, they could have their certification suspended or lose their certification. So EHR could be decertified now. Another thing that they are going to require of CMS is going to require of EHR vendors is price transparency. One of the biggest complaints we hear is my vendors nickel and diming me. Every piece of functionality they turn on is another monthly fee. This has to be, their prices have to be clearly defined on their website and in their marketing material to eliminate that nickel dime.
Okay, and the very last things, just a few mop-up things. Hardship exceptions will still be granted for practitioners who have not met meaningful use or cannot meet it in that given year, but in no case shall exceptions be granted for more than 5 years, and you will have to apply every year. The NPPES and MPES website, which is the CMS umbrella website for providers, will now include direct addresses. And an important note for many of you as you look at new technology is the definition of seen by EP for purposes of meaningful use will, under the Stage 3 regs, specifically include telehealth visits and consults. So it's something to keep in mind when you're strategizing new technology. So other than that, we'd say hang in there with meaningful use. You can't walk away even if you're done with the incentives, and work on getting your HIE connections going to help you meet all of your transitions of care and interoperability. And please, please send us any comments you have about the regs. Even if you're submitting them directly, we'd love to know what you're thinking so that we can craft a common response.
Yeah, and I would strongly recommend that you get your 2015 certified product in place prior to the start of the 2017 reporting year and take a run at Stage 3.
Yeah.
Take a run at it because you still have the option of reporting at Stage 1 or Stage 2, whatever stage you were in 2016, but take a run at it, try it. If you can get a few of your providers through at Stage 3, by all means, man, do it. Take a run at it.
The certification for 2017-2015 edition certification will require the vendors to be able to report Stage 1 and Stage 2 measures, even though they're geared for Stage 3. So you should be able to have that option. So I'd agree with Scott. You don't have anything to lose if the vendor can get you upgraded by 2017 to look at running those measures if you think that you can meet some of them with your workflow. All righty. So other than that, just various things about why meaningful use is important on patient care. Keep in mind there are new grants coming down, so watch for Dottie has you all signed up for newsletters, and we'll send you information on that. So other than that, do we have any questions, Scott?
Let's take a look here real quick. Wow.